Okay, Jacob, you can go ahead and start.
Bob says we're going to have
Okay, the Respiratory Therapist and Polyphotographic Technologies Licensing Board meeting is convening at 9:07 a.m. on March 19, 2021 at the Health Licensing Office in Salem, Oregon by telephone conference call. I will now call roll. Jacob, myself, aye. Halsey? Here. Lepore?
She loves the ducks.
Aye. There. Comfort? There. Patrick?
Aye.
I don't see Mark or Pablo, correct?
You've got to help me.
Correct.
Members, when you wish to speak, please state your last for the record. For the record, public members calling into the public phone line are asked to email April Fleming at april.fleming@dhsoha.state.or.us and provide your first and last name. Public and interested parties' feedback may be heard during the public interested parties' feedback period if indicated on the agenda. Everyone is asked to use appropriate language, manners, and protocols when conducting board business. This meeting is called to order. All right, well, first I think we need to approve the agenda. We have a motion to approve.
Motion to approve. Before.
Second. Okay, we have a motion to approve the agenda as stated with Lepore and Garber seconding. So I will call to order myself. Aye. Also.
Aye.
Lepore.
Aye.
Garber. Aye. Fitzpatrick.
Aye.
Agenda has been approved. Very good. Sylvia,
Some of these kids are playing.
All right, so this is Sylvie. A couple of things. We've got one big update today. Most likely, unless we have a meeting between now and the beginning of May, this will be Tony's last meeting. And so we all want to say thank you and that we appreciate him. We do have a Michael Erickson who has to be Senate confirmed, and he will be taking Tony's place. And Tony, how long have you been on the board now?
8 years.
8 years.
Wow. Congratulations.
Thanks for helping.
Yeah, thank you guys.
It's been a long time.
It has been.
Okay, a few other things. Legislative update. So we're hot and heavy in the legislative session today. Up until midnight is one of the cutoffs. If a bill does not have a work session scheduled by midnight tonight, then it was dead. Will be what we consider dead, which is through the process. And then we have until April, I believe, 14th for it to actually have had a work session in order for it to continue moving forward. So the office has 2 new potential boards and programs coming to it. One program is called genetic counselors. Another board would be sign language interpreters. That one's still in the works. We'll kind of see. And then your guys' fee increase is included in Senate Bill. I have the bill written down here somewhere. I think 5024. It's mixed in with a whole bunch of other Oregon Health Authority stuff, so it's not real self-explanatory, but it's still working through the process. It's currently in the Ways and Means, and most likely will move forward. So those fees will increase effective January 1 of 22. The other big thing that I got was I got an email from the American Association for Respiratory Care, and so they're working on a special project. They asked that I fill out a survey to kind of want to know if the state of Oregon would be interested in an interstate compact program, which is a lot more like, say, that nurses are, where you can more easily move from state to state to state. And so they're gathering information from each state to kind of see how much interest there is. And so I filled out a survey because I am under the assumption that you all would agree that we would want to be a part of that, especially since pretty much the qualifier for anybody to become a respiratory therapist in Oregon is having the NVRC certification. So, which is what we consider in Oregon basically the standard. So there's no I don't feel that there's anything that would reason on why we would not do it. So I told them that we would, that we were interested in it. They're in, basically in the planning phase. It's going to go through a whole bunch of different phases. It's going to take time. They're going to have to get a whole bunch of states on board. They're also going to get a group together that's going to look at all the different laws throughout all the states and figure out ways of kind of synchronizing that. So just want to let you know, I'll keep you updated as that goes. Again, it was just the first stages. They want to make sure that states are interested before they start pursuing it. So any questions on that? No? Okay.
Jacob, did you say which states they're thinking of?
Well, right now they're just gaining interest. How many states are interested in this? So, for one, we now have said Oregon is interested. So I would assume the more states that are interested, which means the more they'll actually start working on it. We only have 2 states that are interested and everybody else says no, they're not going to spend their time doing it. So right now they're in the very beginning planning phases. So I think it'll be quite some time before they actually decide if they want to move forward with legislative stuff. So, but I'll keep you posted. They'll obviously keep me in the loop. So, okay. All right, let's move right along. Licensing and fiscal statistics. So I don't know if everybody has the paperwork or has reviewed the paperwork. So I will go through it. And one of the things that I wanted to ask, we're going to start doing a lot more of these reports in-house, and so we have the ability to start changing them. So what I want to make sure is as we're going through them, if there's still reports that you want to see, if they're relevant, if you don't care, you want different information, something to that effect. So the first one is, and I have an idea because our fiscal years are so odd compared to everybody else. So in the licenses issued, the first one talks about, it breaks it out by quarter, but then by fiscal year. And so at the so over on the left-hand side, it says 2021 fiscal year, and then it says quarter 1. Well, that quarter 1 is actually July, August, and September of 2020. So I think in changing the way this looks will be more self-explanatory because it's deceiving. Because most people think quarter 1 of 2021 would be January, February, March. So that's one of the things that we talked about. So we can get that done up and changed. But are you guys still interested on quarterly to know how many licenses were issued? So on this one, it shows how many respiratory therapy licenses we issued, how many polysongs, and then how many temporaries, and then how many renewals we processed. And then we inserted the special license that we are issuing for the provisional licenses due to COVID response. So we've issued 5 of those so far. And then the next column talks about renewing online and how the percentage of individuals who renew online. Is this still information that you want? Do you want it changed other than the quarterly stuff?
This is before. I think for me personally, I even when I'm not on the board, I would like that information to be public because it certainly helps and has helped us plan in a big way during the pandemic and at other times to get a sense of where our staffing needs are, not only for the hospital, but just for clinics and those kind of things, especially polysomnography techs. So, I mean, I would definitely vote to continue with that just because I think it's important information for not only myself, but also the institution that I work for. So I don't know what other people's thoughts are on that, but it's definitely helpful for us to plan.
This is Jacob. I agree. I would like to see the same report, just with the adjustments that you mentioned. So
Perfect. Okay.
This is Holt. I agree.
Who's that? Who's that?
Tony and Sarah, do you guys both agree?
Yes, Tony, I absolutely agree.
Okay. And Sarah?
And yeah, I do. I think it should be tracked and available.
Perfect. Okay, and then we can keep adjusting as we're going if we need to later down the road. But we'll try and work on getting those quarters fixed because it's always weird. All right, the next one is the long-term trend for respiratory therapists. This one again has those weird quarters, and again we can work on getting that a little bit more detailed, but this just shows the long-term trend, like the very respiratory therapist is very steady, and it's a quarterly average. I think these are also important because you can see the trend, but again, that's just my opinion. But from listening to what you're saying, it sounds like this was probably a good one to leave in there just so you can see the long-term trend.
Absolutely.
Okay.
I mean, it not only for respiratory therapists, but for PSG techs as well, because we had some, challenges during COVID, getting people, whether they're full-time, part-time. And I think going forward, I mean, certainly everything's changed since COVID, and that's going to be really important going forward.
Okay, so I do have a suggestion, because now that we've been licensed, way back in the beginning when we had all the polysoms that were like indirect and direct and temporaries and all working through that program, now that that's going on long enough, I think the two long-term trends, where it talks about the respiratory therapists and the polysomnography technicians, those long-term trends that can be put onto one piece of paper. So you have two trend lines versus one. Is everybody comfortable with that? Get it down to one piece of paper?
The simpler, the better.
Yeah. Fine. All right, so we'll work on that. So we'll get those two long-term trend quarterly ones both on one sheet. All right, and then the next ones are those both for respiratory therapy, and then there's one for polysom, but broken out by age and gender. So it shows how many individuals who are male in the age of 18 to 25 and female 18 to 25, and they're two separate sheets. Is that information important?
Again, I don't, okay, go ahead.
I was going to say, to me, it's just data at this point. This doesn't help me hire or not hire, or project it. That one's not as important to me as the other side. I guess that's what I'm trying to say.
That's true. I do wonder if the public's going to be more interested in that information, to see how many men versus women versus age. Well, age actually is important mostly because of trending. Obviously, the older you are, if your bell curve gets skewed, say, towards the right, towards the older folks, you can expect that, 10 years down the road, you're going to have a hard time getting techs, quite frankly, unless you're getting an influx from somewhere else. So
this is Sarah, and I agree with before on the age one specifically. I think that's important to know.
Okay, we'll keep them.
Yeah, that's funny. I also agree with the age piece, because schools need to know when they need to kick up classes, make larger class sizes.
Perfect.
And even recruit for students as well, so.
Yeah. Okay, perfect. We'll keep them, and you want to keep them separated, because I think if you combine them, it's going to be too busy.
Yeah, you'll be confused with the bell curve if you combine.
Yes. Yep, we'll keep them separate. Perfect. Okay, next slide is the round pie chart that shows the actual snapshot in time. So this one was ran on March 12th, and it shows the actual number of respiratory therapists that are licensed, polysoms, temporary respiratory therapists, and the indirect polysoms, indirect supervision polysoms. Is that one still relevant, or would it be easier just to have those numbers on maybe one of the other charts? Because it's just a snapshot in time. Because if somebody renewed the day after this, it's not necessarily, it's just as of this date, this is what the numbers were. Because that could be on one of those other charts that says as of March 12th. Here's the actual numbers. We could actually put it on the age and gender one.
We can try it, see if it doesn't look too crowded.
Well, because it could just be, I don't know because I have my filter on, but Because we could just put actual totals on the age and gender one, just up in the key where it says this color is for male, this color is for female, and then right below it, the actual numbers. I think that might be better. The downfall is that you're not going to get, because it's constantly changing though, but the temporary licenses and the indirect supervision licenses, those are constantly changing as turnover, you know, and we're more concerned about the permanent. But we'll know how many temporaries we're issuing and indirect supervision we're issuing based on that first chart that shows how many licenses were issued. So is everybody comfortable with that?
Yeah. Do you even need, Fiscal 4, do you even need like a chart? I mean, we just, here's the numbers for
Right,
March
that's
12th, 2021, you know, and not deep dive too much. Because like you say, I mean, it's a snapshot. It could change, you know, 2 weeks from there. So
This is Tony. I probably use that number more than anyone else in the state, and I give it to each of the congressmen and senators a couple of times a year. But I'm not really interested in anything other than the number of RTs in the state that are current license holders. That's about it.
Right, and I think if we put that number in, like maybe the key where it talks about the male, female, age, and gender, so then you could say, okay, there's 594 females and 674 males, you know, and it's just a number that's on there. I think that would work just as good too.
I agree.
Okay, all right, so we're working that. So just so you guys know, Nathan, who does these, is on the meeting. He's obviously has himself on silent, but he's listening to what we're saying and he's going to start doing some adjustments. So we'll work on these between now and the next board meeting. Next slide is the financials. So this shows, again, our weird fiscal years. At least it has the titles up on the top, so you can see that it's July 16th through 2016 through June 2017 for the fiscal year 2017. But it shows each year all your revenues, expenditures, your beginning cash balance, your end cash balance, which obviously keeps rolling over. And then down on the bottom where you can see the ending cash balance. And as of right now, you're in the hole 78,108. And this is as of close of, okay, what month are we in right now? We're in March, so it's probably the end of January. They're always way behind. Obviously, this will get fixed once we have the fee increase. But you can see your expenditures keep going up, and that's part of the cost of being a part of the Oregon Health Authority and the public health unit or division and the assessments that come along with that. So that fee increase will offset that and get you guys up and out of the negative. So any questions on the financials?
So when is it projected to go back into the black?
So the fee increase will not go into effect until January 1 of 22. So it'll be anybody who is applying or renewing after that date will pay the higher rate. Our goal is to over time get you up and out of the negative, not just like immediate, because then it would like triple your fees versus slowly recouping that money. So it'll take time. It'll be a slow transition over time instead of skyrocketing fees and then having to turn around and lower them once the cash balance gets fixed. Does that make sense?
Makes sense. And is there any repercussions for us staying in the red for so long?
No. Obviously, the goal is to make sure that every board is self-sufficient, but the way that the office's model works is that it allows for, because we're 16 boards and programs, so it allows for some to run in the negative temporarily until they get their stuff fixed, because others are in the positive.
So traditionally, we've been positive, is that correct?
That is correct.
Yes.
Yes.
And was it because of COVID that all this changed, or?
Nope, it has nothing to do with COVID. Actually, your revenue's gotten a little bit better because of COVID, because a lot of people are coming out of retirement.
Yeah, well, yeah, right.
Or people let their license lapse because they didn't want to work anymore, they go back in.
Right.
No, it's and you can see that your revenue is pretty consistent. It's not that, it's the expenses. It's the cost of being a part of the Oregon Health Authority and the assessments for shared services and all that stuff. You have to remember, your fees were set when we were independent. So your fees haven't changed since, I think, 2012, I think, was the last time they changed.
Right.
So, which is when we were independent. Yeah.
Yeah, right, okay, I got you.
Okay. All right, let's move on, unless anybody else have any questions about financials. Okay. So next up is policy report, and in your packet has basically an office's legislative session, kind of, this is as of March 16th, and it changes minute by minute. So again, snapshot in time. We still have several bills that we're watching. I talked about a couple of them already. We had a hearing yesterday on another bill, and the dynamics of the legislation this year is way different. Everything is virtual. The Capitol is not open. All of our meetings are just like what we're doing right now, which is very unique to the situation, and a lot of legislators are protesting because the Capitol is not open to the public, and the public's not as easily able to listen and participate. And so there's some unique things that are going on. Like I said, today they have till midnight to schedule a work session, and that means schedule it. They don't have to have had it. It just has to get on the schedule. And so there's nothing that I can think of that pertains to board-related specific. There's obviously a ton of things that are profession-related, but there isn't anything that we're going to have to do as an opening rules or anything like that. So I don't need to talk about that unless there's something you guys want to talk about. There is a bunch of bills that relate mainly towards your profession, maybe, or like when you're actually working, especially if you're working in a hospital, about types of data you need to collect. If you're working with COVID patients in any way, shape, or form, there's a lot of bills talking about that. So those are profession-related stuff that you probably should pay attention to, but there's nothing that this board specific needs to be working on. So, any questions on that? All right. Let's move on. I did have a tab in here too that just says COVID vaccines. Way back in, most of you guys are already dealing with this because you're somehow related to a hospital or something like that. But if you're not, let me know and we can give you some assistance. But back in January, we sent out a lot of email blasts related to vaccinations, who's on the list, who's not on the list, who also they were working on whom could also be added to the list of individuals who can give the vaccine. So there's some individuals who got added to that list, and I would assume most of you guys don't need to know all this information, but if there's anything you guys want to talk about related to the vaccines, I put a placeholder in here for that. Does anybody have anything they would need to say? All right, we will move right along. We are on the regulatory report. Bob.
Hi, good morning, everybody. Bob Balfour for the record. So on the regulatory report, we're still showing 2 biennia. In the 17-19 biennium, we've got 10 cases remaining open out of a total of 84 that we received. And currently, we've received 12 complaints. 9 of those remained open. And to address the previous biennia with the remaining cases open, I've taken one of my investigators and have him pretty much focused on your board cases to try to get this cleared up. But it's just takes time. Any questions? I was afraid I was on muted.
Sorry, Bob.
I was afraid I was muted.
We both keep trying to talk at the same time. So next thing on the list is the letter that came from Calli Johnson regarding respiratory therapists managing vascular access devices. And we put this in there because we didn't know what your guys' thoughts were and wanted your thoughts and then some direction on where you want to go. So has everybody had a chance to read her letter?
I don't know.
This is false, I haven't.
You did or did
No,
not?
I haven't. This is before. I don't think anybody has. Yeah, I don't think anybody has.
Okay, so, well, unless you you guys want to see here, which, and I don't think Dr. Ford can get to it right at the moment. So, basically she wrote a letter and we need to know what you guys, so we just put it in here because we don't know what we want to do with it. But she's talking about how there's 11 other states who openly use respiratory therapists to place and manage vascular access devices, including Arizona, California, Colorado, Georgia, Florida, Kentucky, New York, Mexico, North Carolina, Texas, Washington, and Wisconsin. And so, is that something?
Sylvie, do you want me to, I can read it out loud for everyone.
Sure, yeah, because we need to know what you guys want us to do with it.
Since we have a few that don't have access to it. Is that okay? All right. So this is from Calli Johnson. She's at RT. To whom it may concern, the American Association for Respiratory Care, AARC, updated the respiratory therapy scope of practice in 2018. It reads, the practice of a respiratory therapist, RT, is directed by a licensed independent practitioner and is determined by state licensure laws where applicable. The responsibilities of a respiratory therapist include, but are not limited to, vascular catheter insertion, management, and care. Even earlier in 2015, the AARC released a position statement that specifically addresses vascular access procedures. As outlined in the statement, the AARC endorses utilizing RTs as vascular access specialists. The Association for Vascular Access, AVA, is another professional organization that recognizes vascular access as being within the RT scope of practice. AVA offers a specialty credential, the VA-BC, for RTs who desire to become Vascular Access Board certified. Furthermore, respiratory therapists are one of 6 professional disciplines named in the Infusion Therapy Standards of Practice, the standards, as being capable of placing and managing vascular access devices. The Journal of Infusion Nursing is responsible for publishing the standards. Prior to the 7th edition, the standards were referred to as the Infusion Nursing Standards of Practice. The name was changed from nursing to therapy to better reflect that infusion procedures are not exclusive to nursing, but the responsibility of all clinicians involved in the practice. For example, physicians, mid-level providers, nurses, respiratory therapists, radiology technologists, and paramedics.
What's a mid-level?
Currently, at least 11 states openly use respiratory therapists to place and manage vascular access devices, including Arizona, California, Colorado, Georgia, Florida, Kentucky, New Mexico, North Carolina, Texas, Washington, and Wisconsin. Respiratory therapist Chuck Ramirez trailblazed the path for RTs across the nation when his motion for RTs to perform vascular access procedures was passed unanimously by Arizona's Respiratory State Board in 2007. A respiratory therapy manager for UT Southwestern, Stacy Cutts, followed suit in Texas. The Texas Medical Board officially recognized vascular access as being within RT scope of practice in 2017. Since starting a respiratory therapy-driven vascular access team, UT Southwestern has decreased turnaround time for vascular access device placement from 11 hours to 3.5 hours. While it is more common for internal vascular access teams to limit their services to the placement of ultrasound-guided peripheral IVs, midlines, and peripheral intravenous central catheters, or PICCs, RTs can potentially bridge any gap that exists for all vascular access device types. Midland Memorial Hospital in Midland, Texas, implemented an RT-driven team in 2010 that places central venous catheters, CVCs. 10 years later, the Midland Memorial RT-driven vascular access team has maintained a central line-associated bloodstream inflection, or CLABSI, rate of 0. Contracting vascular access services out to a third party is expensive. The service itself is costly and the price multiplies when CLABSIs occur. One CLABSI costs a hospital upwards of $40,000. Most external vascular access service agencies are paid per procedure and work to place as many lines as possible each day. Accordingly, the placements tend to be rushed and contracted clinicians may be less likely to follow current vascular access best practice. Example, using a standardized equipment kit, working off a procedure checklist, and/or utilizing an assistant during the placement of lines. Respiratory therapists are critical care specialists and are on staff at most hospitals 24/7. Having respiratory therapists who are hospital employees and as such embody the healthcare organization's mission, vision, and values, place hospital patients, vascular access devices, and be in-house to follow those lines for dressing changes and maintenance has been shown to improve infection rates and decrease overall costs. Although respiratory therapists have been placing and maintaining vascular access devices in the United States for decades, this successful application of RTs in healthcare has not yet received the candid discussion nor the open support and acceptance that it deserves. The intent of this letter is to invite key players to participate in this important conversation and request the state of Oregon's formal support of utilizing respiratory therapists to place and maintain vascular access devices. This one step closer to maximizing the respiratory therapy scope of practice in Oregon will improve patient safety, expedite the delivery of crucial therapeutic medicine, decrease healthcare costs, and align with other states' already established position of supporting RTs working as vascular access specialists. The Oregon State's forward response may be mailed directly to me, and she gets the information there. If there are any clarifying questions, please feel free to reach out to me directly at the phone number. Thank you.
So this is before. So these are the same issues that came up with ECMO. For those who within the last 2 years, we've had a candid discussion about, respiratory therapist role in ECMO, and it hinged on one of the main points was actually hinging on this very issue. Part of the concerns were from Oregon law and how this fit into the law. And then, of course, training and access to training was another issue that was brought up. But I mean, realistically, that's not a legal issue, but that was a concern. So, from a background standpoint, that's this issue came up, a couple years ago in a different context, but nonetheless, that was during that time. This is a big part of that.
This is Tony. Reading the letter kind of makes me wonder why I can, without question, start an art line, which is way more difficult than standard vascular access. But everyone balks at us starting standard IVs. We are still, whether we can start them or not, controlled by the meds we can give, what we can push. So I really don't see an issue with IVs. I know there are a lot of states that do train RTs to do central lines. I think that might bring up some other questions. That's a little bit different. I mean, that would be a facility issue where I don't see too many nurses doing central lines. I don't see too many, that's more of a specialty thing, but I think standard vascular access is no different than an art line. It's actually a lot easier to start an IV than it is an art line.
This is Hulse. So my understanding is that respiratory therapists that go on transport, neonatal transport, would be able to put in a UVC line, and that they have been doing this in Oregon, which is vascular access.
That is correct. I know they are doing that in a couple of different places. I know there's nothing specifically stated in our scope of practice that we can't start one. What is stated is we can't give drugs that are not related to the cardiopulmonary system.
This is Holt. I believe that we should support this effort with the caveat that there has to be specific training, whether if they're going into doing things like that are broader than the current practice in Oregon, then they need to have this kind of credentialing that they were talking about that exists, or evidence training that's kept in, that's able to be submitted.
This is before. I would agree with that. If you're going to do any program, you got to have standardization. So it's not something that's routinely taught, at least in Oregon. But also, we need to make sure that according to the legal statutes that were in place, since the 70s, that it complies with that as well.
Yeah, this is Tony. Can we look at how the nurses do it? Because I know Washington is using RTs to start PICC lines. They do have to go through specific training to start PICC lines, but can we take language that Washington uses or even the nurses in Oregon use to, everyone has a specific IV class that they have to go through, or you have to have very specific training to do specific tasks? Can we look at other professions' language and see what we can come up with?
Oh, absolutely. We can do whatever you guys want. That's the whole point of this conversation. Is you need to where are we going to go from here? Yes.
Yeah, I think getting information from established places, places that already do training, places that already, quote, board certified. I don't know what she quite meant by that, but board certified people in, IV starts and such would be a great benefit.
This is Hope again, and I don't really know whether there's actually a need for additional people to be putting in PICC lines, respiratory therapists in Oregon or not, but I think it's important to use this effort to protect the access that we already participate in. If there's people already putting in art lines, if they're putting in UVC lines, I think that we should stand with this effort to provide the best protection for those individuals, and that practice is current.
Yes, absolutely. Sarah, do you have anything you'd like to say?
Yeah, I'm kind of in full support of actually protecting the scope of respiratory care, and coming from the academic side, we have to train our students and educate them on this stuff for their board exams, and it is really hard when they don't actually see it in Oregon. They don't see RTs doing it, and we do have to say, oh, they do it in other states. It kind of becomes facility by facility. So I'm in full support of RTs working to their full scope of practice when it's needed, when it's safe, when the education is in place. And I would say that, and maybe not in Northern Oregon, but in Southern Oregon, there is a demand for just healthcare in general. The larger facility down here is building a second ICU tower, and there's not enough staff yet. And advancing adult critical care specialists, and I'm not saying RTs need to run in and start putting in central lines tomorrow, but I think we should start supporting and exploring the options that they can do this, if there's not enough mid-levels, if the ICU positions are busy. So I think it's a really important conversation to have, and that it should be done correctly and safely. So I'm in full support of kind of looking at this further.
Okay, so I have an idea. You tell me. Sorry, Jacob, is there anything you want to say about this before I move on?
No, I agree with the team, but I do personally need to do just more research because I'm coming from administration and sleep and not RT.
Right. So to add to that, I think what we need to do first is to have Heather make sure that there's no statutory issues. Kind of like with the whole ECMO thing, for those who've been around long enough to hear that one. So let's have Heather do a little digging, or whomever Heather delegates it to. But let's do a little digging to make sure that statutorily there's no issues with this, and if there is, maybe a way of addressing that first. And then once we know that, we'll know how to be able to get it into rule. That say, here's, you're either able to or not. You're able to do this, and if you do this, you must have training, you must have however many hours, whatever we end up coming up with down the road. So let's do one step at a time. We'll take this information, Heather and her group will do some sort of analysis of it. We'll get it on the next agenda, hopefully, or soon thereafter, and kind of give you a where we are based on this and what our statutes are currently written. Is everybody comfortable with that?
Yes.
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 Okay, sorry, Heather. But you're welcome to assign it to somebody else in your office if they want to work on it. Just to make sure that we don't have any issues before we start moving forward. Okay, all right. Well, that's what we'll do with that. Okay, so now we're going to get into the fun stuff. So nobody on here has to cut out. So I can't remember if we've done an executive session in Teams yet. So we have the public who is on a different line than all of us. So, because we're going to go in and out of executive session like several different times. So Jacob will do a lot of reading. But there isn't anything that you guys have to do other than be a little bit patient with us. We've got to turn recordings on and off, but you don't have to hang up. You don't have to do anything. We figured all that out, so it's less annoying for you guys. But we are going to move on. So we're on item number 6. So this is your, Jacob, your first executive session script. You should have 1, 2, 3 of them. So this will be your first one.
The Respiratory Therapist and Polysomnographic Technologist Licensing Board will now meet in executive session pursuant to ORS 192.660-2F, ORS 192.3559A, and ORS 40.225 for the purpose of considering information exempt from the public disclosure at 9:49 a.m. on March 19, 2021. Representatives of the news media shall be allowed to attend the executive session by conference call and will be provided further calling instructions shortly. Public phone line will be muted for the duration of the executive session. Are there any representatives of the news media on the public phone line?
This is Bob Bothwell at the office. Is there anybody on the phone line? Nobody on the phone line.
Recognizing there is no news media in attendance, the public phone line will be muted for the duration of the executive session. We will return to open session before taking any final action or making any final decisions. We are now in executive session.
Thank you.
All right. Well, the Respiratory Therapist and Polysomnographic Technologist Licensing Board will now exit executive session and reconvene open session at 10:15 a.m. No final decisions were made and no votes were taken in executive session. The public phone line has been unmuted and representatives of the media may once again report all board discussions and actions. Okay, the Respiratory Therapist and Polysomnographic Technologist Licensing Board will now leave the public meeting pursuant to ORS 192.6901 to deliberate on a contested case at 10:15 a.m. on March 19, 2021. Deliberation will not be recorded and no final decisions will be made. Okay. The Respiratory Therapist and Polysomnographic Technologist Licensing Board will now reconvene open session at 10:35 a.m. No final decisions were made and no votes were taken. The public phone line has been unmuted and representatives of the media may once again report all board discussions and actions.
Bob, are the recordings up and running?
Yes. Yes. Affirmative.
Yes, okay. Go ahead, Sarah.
Okay, in case number 17-8654, I move the board recommend to HLO to not withdraw the final order and not accept the voluntary surrender of license.
Anyone second that motion?
This is Halls, I second the motion.
A motion has been made. I'll call roll. Jacob Espinosa, aye. James Halls?
Aye.
Michael LaFleur?
Aye.
Tony Garber?
Aye.
And Sarah Fitzpatrick?
Aye.
Okay, motion has been passed.
All right, Jacob, you have another script to read. You're off a lot of reading today. You have another script to read for item number 9.
Oh, we're going back to the executive session. That's correct. Can I ask for a quick coffee and potty break before we go back?
No.
Oh, absolutely. So, Bob, make sure that all the recordings and everybody's paused.
We're good.
Heather's back. We've got everybody. So if you want to go ahead and read the script for item number 9. Oh,
Okay.
wait, hold on. Bob, I can't see you. Is everybody in the room ready?
Can you hear me now? We are ready.
I can hear you now. Is everybody in the room ready?
Yes. Recordings are
Okay,
going.
Go ahead, Jacob.
Yes.
Okay. Well, the Respiratory Therapist and Polysomnographic Technologist Licensing Board will now meet in executive session pursuant to ORS 192.6602F, ORS 192.3.35598, and ORS...
Jacob, I think you are reading the wrong one. You're probably reading the one from the first one.
Oh.
So it should be one, the
Yeah.
third executive session one.
My apologies.
Is that right?
I thought it was a duplicate.
Nope.
I'll restart on that. The Respiratory Therapist and Polysomnographic Technologist Licensing Board will now meet in executive session pursuant to ORS 192.6602F and ORS 676.595 for the purpose of considering information exempt from the public disclosure at 10:49 a.m. on March 19, 2021. Representatives of the news media shall be allowed to attend the executive session by conference call and will be provided further call instructions shortly. Public phone line will be muted for the duration of the executive session. Are there any representatives of the news media on the public phone line?
Hi, this is Bob from HLO. Is there anybody on the phone, the public phone? No.
No.
Recognizing there is no news media in attendance, the public phone line will be muted for the duration of the executive session. We will return to open session before taking any final action or making any final decisions. We are now in executive session. The Respiratory Therapist and Polysomnographic Technologist Licensing Board will now exit executive session and reconvene open session at 11:05 a.m. No final decisions were made and no votes were taken in executive session. The public phone line has been unmuted and representatives of the media may once again report all board discussions and actions. We are now in open session.
All right, Bob, is the recording up good?
Yes,
Good.
ma'am.
Sarah?
In case number 18-0, in case number 18-9039, I move the board recommend to HLO to revoke the license and impose costs for hearing.
This is Tony Garberg, I second the motion.
Motion has been made. I'll call roll. Jacob Espinosa. Aye. James Holtz.
Aye.
Michael LaFleur.
Aye.
Tony Garber.
Aye.
Sarah Fitzpatrick.
Aye.
Motion has been passed.
Excellent. Thanks, you guys. We're on the last agenda item, number 11. Any other board business? Bob, I'm assuming Sammy's in there. What day is their next board meeting scheduled?
That would be October 8th.
Until October?
Yeah,
That's what Sammy said.
already prepared.
So, is there, I hate to be the party pooper, but I will be in the Bahamas at that time.
Oh, darn it.
Oh.
So, then we can move.
You can team in. It's fine. You can team in. We're cool with that. Listen, if I can do it from San Diego, you can do it from the Bahamas.
Why?
Is it seriously not till October?
It's seriously not till October.
Sammy said seriously, not till October.
I double,
What do we
triple checked.
believe then?
Well, I don't know. But she says, she alleges she doubled and triple
I
checked.
did because I didn't believe it.
She didn't believe herself. That's why she triple checked.
We're on the
So
COVID schedule.
Jacob, we should be fine. You're allowed to take vacations, and that's why usually we have a vice chair or
Yeah.
something in place where somebody else can run the meeting while you're gone and enjoying your vacation. So, other than that, any other board business for item number 11? So one of the things I was thinking, October's an awful long ways away to be able to respond to that letter that we got from Callie Johnson. And so, depending on Heather and her schedule and whom she assigns that letter to, We may have a meeting prior to that to be able to talk about that and kind of figure out where you want to go. Sammy, if you'd reach out to Callie, kind of let her know, Callie Johnson, not Callie Worker, kind of, that the board reviewed it and they're doing some further research and get back to her so she doesn't feel like if we don't meet till October that we're ignoring her.
Yep. Yes.
Perfect. All right, so there's a potential there may be something before October due to that, so it'll kind of depend on Heather and her schedule. So other than that, I guess we'll see you in October.
This is Bob. If we get some cases pulled together, we'll reach out to the board and get them together for that. Since it sounds like they're going to miss us, I don't know.
Yeah. Yeah, so I want to reiterate that Tony will not be on the board again, so this will be your last interaction with Tony. And we want to thank you, Tony, and you'll get your
Dr.
plaque in the mail. I don't have it sitting in front of me because I'm not in the office, but you'll get your plaque in the mail for your 8 years of service.
Thank you, Tony.
And the cash money.
Yeah, thank you guys very much.
Good.
Thanks, Tony.
Yeah, absolutely.
Yes, thanks, Tony.
Good to work with you all.
That's right.
Absolutely.
You get $30 stipend. Congratulations.
Does anybody have anything?
Nope.
Nope. Okay, Jacob, you have yet once again more things to read, so you should have a one-liner on closing the meeting out.
I was about ready to shred these. Okay. The Respiratory Therapist and Polysomnographic Technologist Licensing Board meeting is adjourned at 11:09 a.m.